Thank you for the opportunity to present to the Society the results of this study entitled Pattern Analysis of Proangigenic Plasma Protein Elevations Noted After Minimally Invasive Colorectal Resection. The human perioperative blood protein data assessed in the study was generated in 10 separate studies carried out over 12 years of colorectal cancer patients undergoing bowel resection. These are our disclosures. Of note, some of the blood samples used were donated by the Cleveland Clinic, Ohio, and the Ferguson Clinic, Spectrum Health, Michigan. A wide range of murine studies suggest that surgical trauma is associated with accelerated tumor growth. Clinically, the rapid development of distant metastasis has been noted within 2 to 3 months of surgery in case reports in small series. The mechanism of increased tumor growth is unclear. Some believe that immunosuppression is the cause. Others believe the primary tumor suppresses the growth of the metastasis and that once it is removed, the mets grow rapidly. Lastly, some believe that the systemic alterations are to blame. The blood levels of a large number of proteins are transiently elevated after surgery. The great majority of these changes resolve within 1 to 4 days. There are, however, a small number of proteins whose levels remain elevated for 3 to 5 weeks after surgery. Interestingly, all of these proteins promote angiogenesis. Here is a list of the proangiogenic plasma proteins whose blood levels are elevated for about 1 month after minimally invasive colorectal cancer resection. Each of these graphs show the weekly post-op blood levels for each protein. Note that 2 bars are shown for each data point. The right bar shows the average post-op level, while the left bar shows the mean pre-op level. It can be seen that the post-op levels are higher than the pre-op results. Do these protein changes have any effects? It can be seen here that the growth and migration of endothelial cells, which are critical to angiogenesis, are increased when incubated with postoperative blood plasma when compared to results obtained with preoperative blood plasma. What is the cause of the blood protein changes? The early, rapidly resolving changes are most likely related to anesthesia and trauma-related acute inflammatory response. The more persistent elevations are thought to be related to wound healing, which is a lengthy process. The authors believe that the long-duration changes may stimulate tumor angiogenesis and therefore growth in tumor deposits that remain after the primary is resected. The purpose of the study was to assess the different patterns of elevation after surgery and to consider the possible importance of these patterns. We believe that different patterns of elevation occur after surgery. This study assessed the patterns of elevation of 15 of these proteins. Different patient populations were used for each of the 15 separate studies that were done over a 12-year period. These studies were done with plasma from 312 patients who underwent minimally invasive colorectal resection. 65% were laparoscopic assisted, while 35% were hand-assisted cases. The N for each protein assay varied from 73 to 105 patients. Blood samples were processed and the plasma from each sample stored at -80 degrees Celsius until used. All patients had pre-op, post-op day 1, and post-op day 3 specimens taken. In addition, 1 or more late post-op samples were taken during the first 5 weeks. Late samples were bundled into 7-day blocks that were considered as single time points. Plasma protein levels were determined via ELISA in duplicate and the data was analyzed via t-test. Compared to pre-op levels, 10 of the 15 proteins were elevated at all 5 post-op time points, and 5 proteins were elevated at 3 to 4 of the 5 post-op time points. 9 proteins peaked during the first week after surgery, 3 proteins during week 2, and another 3 had even a later elevation pattern. This table shows the mean protein concentrations for each protein and time point. The patients are grouped by color according to the elevation pattern. This graph shows the percentage change from baseline of plasma levels for each protein for the proteins that peaked in the first week. The 2 leftmost bars of each grouping are the first post-op week results. The levels of these 3 proteins peaked during or close to the second postoperative week as shown by the purple bar. These 3 proteins have a somewhat later elevation pattern. In summary, colorectal resection is associated with an increase in plasma protein levels for 91% of the time points in the first month after surgery. Significant mean elevations were noted for all proteins during the first 3 weeks after surgery. Elevated levels were also noted during the 3rd and the 4th post-op weeks for 12 out of the 15 proteins. Most proteins peaked early, while 6 had late elevations during post-op weeks 2 and 3. The etiology of these long-duration protein elevations is uncertain. However, the acute inflammatory response that follows surgery almost certainly is a major contributor during the first week after surgery. As regards the later elevations, the authors have strong evidence that the healing wounds are a key source. The clinical relevance of these changes are unclear. It is feared that patients who have residual tumor deposits are at a higher risk for accelerated growth during the first month after surgery. As regards next steps, we hope to determine the post-op levels of these proteins on a single population of patients in order to identify the patients with the most marked protein response to surgery. We hypothesize that these patients are at a higher risk for development of tumor recurrences in the first 3 to 4 months after surgery. Further, we believe that early post-op anti-cancer therapy may be indicated for high-risk patients.